Hey everyone. So we will get Shawna to go ahead and start her session. Welcome. George, did you have something you want to share?
I do. Shawna's, I'm George Simpson. I'm with the foundation, and I'm only here to introduce Shawna and to field questions on her behalf. I will tell you that she is an extraordinary genetic counselor with a specialty in CMT. She works with the Inherited Neuropathy Consortium and helps to coordinate the 20 sites that are enrolling patients with CMT studies across the INC. She's a former college professor. She's been published extensively, and I'm simply going to turn it over to Shawna. Shawna.
Well, thank you for that nice introduction and for inviting me to be here. I'm going to focus on folks who may not have their a known genetic type defined yet, and sort of how CMT is diagnosed and how we approach that. So first, I'm going to start quickly by defining CMT, and CMT is many diseases, so we'll talk about that. And then I'll also look at how we diagnose CMT, as well as how it can be passed along in families and how that helps us diagnose a certain type of CMT. And then we'll look at defining the different types, genetic testing, reviewing labs and how we approach that, and then how genetic counselors can also help, as well as the INC. So as we know, when we're talking about CMT, we're talking about a problem in the peripheral nerves. So those are the long nerves that leave the spinal cord and go out to the hands and the feet here. And we kind of broadly describe a couple of different forms of CMT, and that's where people may have heard of those numbers like CMT1 and CMT type 2. So all of those are forms are types that affect the peripheral nerve, but they affect it in different areas. So the classification of CMT type 1 simply means that the problem is starting in the myelin or the outside part of the nerve. And if their problem is starting in the axon, then we refer to that as a CMT type 2. But in general, the symptoms that can occur in these different types can look very similarly. So we use other clues to help us define how, where the problem is starting and what type of CMT a person might have, as there's over 100 different genetic types now, so it can be complex. So CMT really is an umbrella term, and it's defined by, more specifically by how it's being passed on in a family, what we call the inheritance pattern. We use autosomal dominant inheritance, X-linked inheritance, and autosomal recessive inheritance to sort of help classify what type of CMT a person has, and then also how it's affecting the nerve. Once a specific genetic cause has been identified, then people get that letter after their diagnosis. So like CMT1A, for example, helps us know this is the specific genetic cause that the person has. But like I said, there's over 100 different genetic types, so it can be complex. And this is even an outdated picture. The linear bars are each chromosomes, and you can see that there's many genes on every chromosome that can lead to CMT. So these are each individual genes or types of CMT. And so it's not one disease because there's so many genetic types. It's also can vary in terms of symptom presentation based on the genetic type. So not everyone looks the same. And selecting the right genetic testing can be complicated and may not always lead to answers for everyone. Like they were mentioning in the talk before, there are a significant number of people who do genetic testing and still can't find answers. So genetic counselors like myself help to navigate this process. So the question is, how do we get from here, where we have a person with CMT in our office who clearly has sort of classic signs that dropped foot, picking up their foot, and some changes in their hands, to a diagnosis? And that's what I'm going to try to walk you through. It's also especially important to remember, like I said, that there's many different types of CMT and they can all look very differently. So this is a very more severe form of CMT that we helped to identify in this young girl And unfortunately, she passed away from her symptoms because they are more extensive, involved respiratory failure and things like that. And you can read more about her story, which was published. So the inheritance pattern, or how the CMT is being passed along in the particular family, nerve conductions, which is everyone's favorite test, that show if the speeds are slow or if there's a problem with the axon. And also the clinical history and exam, like when did symptoms start? How do they progress? What do they look like now? All of those are clues to help us define CMT. So I'm going to quickly kind of go through a reminder of modes of inheritance or inheritance patterns. The main ones we're talking about here are autosomal dominant, recessive, and X-linked. And again, this looking at families and drawing up a family history, which is what I do in clinic many, many times a day, helps us to look for these patterns in a family. So remember that our chromosomes are just kind of packages of genetic information, and that genetic information is our body's recipe. It tells our body and our cells what to do and how they're supposed to do it. And it's easier to look at chromosomes in a picture format like this, because then you can see that they come in pairs. We get one of each pair from mom and one of each pair from dad. And the first 22 pairs are the same, but the last set are what determines gender. So males have an X and a Y chromosome, the Y chromosome making them male, and women have 2 X chromosomes and no Y chromosome. That becomes important when we're talking about types of CMT that are inherited on, for example, the X chromosome. The other thing to pay attention to is dominant versus recessive. So dominant versus recessive, it's not, we're not talking, when we're talking about autosomal dominant or autosomal recessive, we're not talking about these gender chromosomes. We're talking about the chromosomes that are the same between men and women. And for dominant forms of CMT, you only need to inherit a change on one copy of the chromosome in one copy of the gene in order to show symptoms. For recessive forms, you need to inherit changes on both copies, changing the function of both copies. And so that's the difference there. And that will change how CMT is passed on in the family and the risk of people in the family. So in dominant forms of CMT, like we were talking about, for example, these would be bars or chromosomes. You only need a change in one parent in one copy of the gene in order to be able to pass it on. So the other parent doesn't matter, matter what they're contributing, because of having a change in one copy of the gene in this circumstance is enough to cause symptoms of the condition. So therefore, every time someone with CMT with a dominant form has a child, they're going to either pass on the chromosome with the change or the one without. So that's where that 1 in 2 or 50% chance comes in. And very classically, that's an example of like CMT1A. That's how it's passed on. If someone does not inherit it, they can't pass it on. If they inherit it, then they have the same 50% chance. And this is what we see in terms of a family history for people with autosomal dominant forms of CMT. You're typically going to see someone in every generation affected, but not always. And you see a male passing it on to a male sometimes. So that you don't always see that depending on the family structure and stuff, but in autosomal dominant inheritance, men and women have a 50% chance of passing it on to each child. The receiving gender of that child does not matter. Sometimes you can have CMT starting, a dominant form of CMT starting right out of the blue. So you won't see this family history, but this is what we're looking for. And I should mention that women are circles here, are indicated by circles. Men are squares. Sorry, guys, that's just the way it is. And when we have the colored in boxes, that indicates someone who has symptoms. CMTX is a little bit different. And I have a lot of people think they come in that they have CMTX. So I'm going to try to explain this. So this is a mom with CMTX. Remember, she has 2 X chromosomes. The dad in this case doesn't matter, but he has an X and a Y. So for mom, she has a change in one copy of her X chromosome, Every time she has a child, doesn't matter the gender, she's going to have a 50% chance of passing on that X chromosome with the change, or a 50% chance of passing it on the one without the change. So 50% either gender. However, because mom and other women in the family have this other X chromosome, that may make her symptoms a little milder. And so then when we see men with CMTX, because they don't have that other X chromosome, they can be a little more severe. So we look for that pattern in families. However, when dad has a CMTX, for example, he can only pass on his X chromosome to his daughters, because that's what makes them daughters. And he'll pass on the Y chromosome to all his sons. So in this case, 100% of dad's daughters will be affected, but none of his sons. And that's where things get a little tricky. But when we're doing a family history, we're looking for a clue where we say no male to male transmission. So there's no father passing it on to a son. And that helps us to define if the family history could be an X-linked family history. Finally, the last inheritance pattern I'm going to describe is recessive. And that's where parents are carriers, but not affected themselves. They have only one change in each copy of their gene, but remember that with recessive, you need to have changes in both. So every time they have a child, in this situation, there'll be a 25% or 1 in 4 chance of having an affected child that inherited changes from both parents, a 50% chance that the child will be a carrier, inheriting a single change from one of the parents, and a 25% chance that the child will not be a carrier and will not be affected. For people who have a recessive form of CMT, all of their children will be carriers, but it will be close to a 0% chance that they have an affected child. So these inheritance patterns are clues for us, but they also, if we can define the genetic cause for a person, they become pretty impactful in a family, because this is what determines what the risk is to children. And so if you have a recessive form of CMT, the risk can be close to 0%. If you have a dominant form of CMT, the risk would be 50%. If you have an X-linked form of CMT, that risk, if you're male, for example, and have a daughter, that risk is then 100%. So you can see how dramatically that can change in a family based on the type of CMT a person has, which is why sometimes people decide to do genetic testing. And this is an example of a recessive inheritance where you might just have a single person affected, but we can't be fooled, because again, sometimes people with dominant forms of CMT can just be the first person in their family that's affected. So again, how do we go from our inheritance and our gentleman here to moving on to a diagnosis? So we take his family history, we see this pattern, we see male to male transmission, so we know this is an autosomal dominant form of CMT. In this case, we do nerve conduction studies, and that's to orient you. This column here is where we're looking at the speeds in meters per second. Those should be about 50 meters per second. You can see that they're about half of what they should be. So these are too slow. And so this would indicate that the problem is starting in the myelin, the outside part of the nerve. So already we have a dominant inheritance. We know that it's demyelinating, and we're starting to classify this as a CMT type 1. If this would have been axonal, then you would see changes in the amplitude or the strength of the signal, but you wouldn't see speeds that were normal, about 50 meters per second. So then that would point us to a CMT type 2. So back to our umbrella, we have dominant inheritance, demyelination. And so in this case, for this person, based on how his symptom progressed, where he looked like now, and in these factors, we would narrow testing probably to CMT 1A, which is the most common form of CMT. People have been talking about that all day and the advancements in treatments. Essentially, this is an extra copy of a gene called PMP22, peripheral myelin protein. So protein in the myelin, in the peripheral nerve, 22 just refers to the size. And this is located on chromosome 17, same number between men and women. So you should have 2 copies of that gene because you have 2 copies of that chromosome. But for people with CMT1A, they have an extra copy of this PMP22 gene, which is creating too much of that protein and disrupting the myelin function. So that's where research is going to sort of silence or block that extra copy, so it's no longer producing an excess amount of that PMP22 protein. And we know that this is a dosage problem that can happen in reverse as well, where people can just have one single copy of this gene, and it also causes a problem. So having a deletion or a duplication are both an issue. And we know, so for this particular gene, it's very important to have the right amount, or you disrupt the function of that myelin. However, duplications and deletions are not the only thing that can happen in a gene that makes it have a problem in terms of function. So recall that in a gene, our genes are represented by a genetic code, very simple alphabet of 4 letters broken up into 3-letter genetic words. Each genetic word tells the cell, okay, you need to make this specific amino acid. And those amino acids are strung together like beads on a string that make the proteins that function in our body. But when there's a spelling change, it may tell the cell to make an incorrect amino acid, which can disrupt the function and cause an abnormal protein. You can also have problems where there might be a deleted part or extra pieces, letters put in, and that can disrupt the function of the protein. So when we do genetic testing, sometimes we're looking, or what we call sequencing, or looking at this spelling arrangement to see if there's spelling errors, deletions, insertions, things like that, that could lead to an abnormal protein. Genetic testing is really rapidly advancing, and it's offered in many different ways. So there's not really one genetic test out there. You can, for example, use the symptoms like we did earlier for our gentleman, and narrow that down to a single gene that you might want to test, like PMP22. Or you might just want to focus on some of the more common genes and do sort of a small panel. Genetic testing is becoming, less and less expensive, but a lot of times as you grow and increase the number of tests or genes that you're testing for, you can also increase the cost. Nowadays, a lot of genetic testing is done in gene panels, where you may have 100 or 300 genes that are known to cause that subset of symptoms. So like, for example, we might order a CMT panel, which has genes that are known to be associated with CMT. But not everyone can find the answer that way, because we still don't know all the genetic causes of CMT. And so then sometimes people move to what we call a whole exome. An exome is all the protein producing parts of the genome, and that's about 1% of the genome, but it's also about 20,000 genes. So we're getting from 100 to 300 genes to then 20,000 genes. So that's a big leap. And then there's whole genome testing as well, much of which we don't know really what it does yet. 85% of human disease is currently found in exome. But the more you test, the more you find, and some of it are things that we don't know. So some of you may have run into what's called the variants of uncertain significance. And those are challenges medically, because it can be difficult to interpret what that means, since they may be unique variants, haven't been seen before, and haven't been classified. And so we don't know if they're just a benign change that is unique to you or leading to your symptoms. And as I mentioned, the greater number of testing you do, you might also include an increase in costs. So we try to narrow testing as much as possible based on symptoms. And this is just an example of a lab report and showing you kind of how complex it can be. For example, each of these is one gene. And this one individual had 3 variants of uncertain significance. The benefit here is they also did find a change in a gene called GJB1. This leads to CMTX. But the problem is that all these might also be medically impactful to this patient. So as a genetic counselor, I can't just say, okay, we found the answer. I also have to say, okay, what are these? Could they be impacting my patient or their family? And there are, as you know, lots of different genetic testing labs now available. So it's really hard to navigate. And not all genetic testing is the same. Labs differ in the cost, what insurance is accepted for coverage, the genes that are on those panels, so they're not all the same, and the number of genes. They also change from year to year because new things are published. So genetic counselors can help people navigate through this process. So going back to our overwhelming slide of the number of genes that we are talking about here, not everyone can, even with commercial testing and doing a large panel, find the answer in currently available genetic causes for CMT. So we call this commercial testing or clinical lab testing. And some families go through that and they are not able to find their genetic diagnosis. In fact, a significant portion, like 40% of people who have CMT type 2 will find themselves in this scenario where they can't find the genetic cause. So our Inherited Neuropathy Consortium, one of our aims is to identify new causes of CMT using whole genome or whole exome. And so this is genetic testing being done on a research basis. So it doesn't go through your insurance and it doesn't go through a commercial laboratory. It comes to our program. It allows us to look at many genes at one time and look for new genes that a commercial lab wouldn't be able to report on, because commercial labs or clinical labs are required to have publications that they know show that this particular gene is associated with that particular condition. In research lab setting, we can look at other genes. And for example, this is how SORD was identified across our consortium, the gene that was just being discussed. But this is a lot of information we're sorting through. If you were to print out the entire human genome, as this group did, you can see how many books this would fill. All the books in yellow are just chromosome 1. So that's just on a single chromosome, how much genetic information there is. And so this is a lot of genetic code to sort through to find or identify a person's genetic cause of their symptoms if they're not easily done through commercial laboratories. And just to show you, this is an example of this process. We collaborate with the University of Miami, who has this platform that we use to help to go through and screen data and look at potential causes. So I'm just going to show you this as an example.
All right, I'm going to select my individual. And we will analyze. This is one person, one patient who has an inherited neuropathy. I will go to my filtering section. So we're focusing on dominant forms of inherited neuropathies. We've selected for genes that could be related to CMT, and then we'll analyze. This is what the output looks like. So you can see that this is one individual. So I mean, across the population, it's either rare, meaning hardly seen, or private in that single individual and hasn't been seen in the general population. And as we scroll through, you see each line is a single variant. So each of these would have to be investigated, determine whether they are actually causing the patient's symptoms. And many of them, even though they're private or rare variations, are just benign changes that don't lead to any type of disease. And so this is the proverbial needle in a haystack to find the cause of the individual symptoms, but this is how we find new genes.
So 6602 is our gene discovery program, and there's other tools that we use. For example, these are samples that come to us and they're de-identified, but in a de-identified way, we can cross-check each individual's genetic information across people who've enrolled all over the world into the INC for this process. And that's how SWORD was identified, as they were able to find many patients in multiple cohorts, all in various countries. And so that led to a new identification of a form of CMT. So I hope this kind of helps clarify that when we're talking about CMT, we're not talking about one disease, and diagnosis can be complicated. There's not a single genetic test. There are many labs and many different types of genetic testing that can be offered, and not all tests are the same and they change over time. So genetic counselors help families to navigate the system and help to define what tests might be most appropriate and in a cost-effective way. So using 6602, our gene discovery program, we've been able to identify over half of the currently known genetic causes of CMT. And so just to touch base again on genetic counselors, and you can find a local genetic counselor near you at our organization called nsgc.org. But genetic counseling is the process of helping people understand and adapt to their medical, psychological, and family implications of genetic contributions to disease. We help guide people through the testing process, facilitate the most cost-effective approach, identify the most likely way to get a positive result, positive meaning identifying the genetic cause. We review pros and cons of testing. Not everyone decides to do genetic testing. So we take a non-directive approach so people can make an informed choice about testing. And we interpret genetic information and help inform families and educate them. So some of the reasons why someone might want to do genetic testing is to determine if other family members are at risk, to see if they can do family planning options to prevent passing it on, which is also a personal choice. They may want access to future clinical trials, and we've seen today just how much is going on in the clinical trials. And for now, at least, all those approaches are really type specific. So you kind of need to know the genetic cause in order to have access to that. And some people just want to have a definitive diagnosis. They've dealt with CMT for years or decades, and they just want to know what's causing this. Why, are my feet like this, stuff like that. So all of those are valid reasons. Family plannings options, which I can touch on. There's ways to have your own biological children without passing CMT on. There's different options either during pregnancy or before pregnancy. Those are personal decisions, but knowing the genetic cause is essential to having that option. There's obviously other ways of growing family through donation or adoptions, like embryo adoptions, or donor options like sperm or egg donation. The negative or kind of reasons why people might struggle with genetic testing is they may decide to do it and then they have inconclusive or negative test results. And then now what do they do to find those answers that they were wanting? There can be emotional impacts on the family system or positive or negative results. Even in like cases where we see someone who did not inherit the genetic cause for the CMT in the family, sometimes people can have survivor's guilt or feel upset their sibling or someone is going to go through decades long of symptoms that they won't have to experience. Genetic testing may not be available. Like we said, CMT type 2, a lot of folks with that diagnosis don't end up identifying the genetic cause. And so then they're struggling with, do you do research testing? What's the next steps? And some people have concerns about genetic discrimination, but they're also, we encourage people to be knowledgeable about what protections are in place for people who have or are at risk for genetic disease. These are separate than some of the things that are in place for like pre-existing conditions that people hear about through like the Affordable Care Act. Genetic discrimination laws, like for example, GINA, the Genetic Information Non-Discrimination Act, were instituted prior to that. They're federal policies that started in 2008, and that protects people who are at risk for genetic disease. So that information can't be used for their employment or for their ability to get access to health insurance. There's some limitations to that, but there is information out there on the web, such as a form called GINA and You that you can look up. And then HIPAA, some people obviously, we know HIPAA, we sign every time we go to the doctor, we have to sign for HIPAA, and people think of it as a privacy thing, but there is one of the P's of HIPAA is portability, and that means that you can access or get health insurance even with having a condition, and there's stipulations on how that works, but that people can transfer to other health insurance, and that's part of HIPAA as well. Cost always comes up, in most conversations that I have with patients. And like I said, genetic counselors can help you navigate that. But since genetic testing has changed so significantly over time, costs have come down. Labs are competitive with each other in terms of cost, but also that has helped drive the advancements in genetic testing. So if you looked into, doing genetic testing 10 years ago, 5 years ago, even a couple of years ago, those things have changed. And so you might want to investigate that or talk to a genetic counselor. I've heard a lot that people say, well, I asked my doctor and they said, well, it's not going to, change your diagnosis, or, it's too expensive. And that was maybe true long ago when our technology was different, but costs have really changed. So if that's the message that you received a while ago, I would reinvestigate that, because we really can try to help navigate patients to appropriate genetic testing in a cost-effective manner. There can be other issues that come up. For example, do I test my child? When did test children? A lot of times, if a child is symptomatic, then we might approach getting genetic testing. But if they're not symptomatic and not clearly having any medical issues where you would need intervention, we may hold off on genetic testing. And then there can be non-paternity issues that always come up in any type of genetic testing. So these are the things we talk about during this session. This is our website for the Inherited Neuropathy Consortium. And I think I heard during the last session, people were asking how they can find a site near them. If you scroll down on this site, there's a section where you can get involved or join research here, and it'll indicate where those sites are. At our sites, we are doing a variety of different studies. A lot of those are, getting ready for clinical trials. So what we call clinical trial readiness. So those are natural history studies, developing outcome measures. I got a little tickle. Developing or identifying biomarkers. And then identifying new forms of CMT, like we mentioned, all for the preparation of being ready for interventional trials. And these are our sites. Again, you can go on our website as well to find those. And I've also listed my direct email. I'm the project manager for the INC. So I'm going to stop there and answer questions if I can with my voice right now.
Thank you, Shawna. That was a ton of incredibly useful information. Go ahead and get that tickle taken care of. I want to remind everyone in the room, and there are about 20 people in the room at this point, that we need you to use the Q&A button at the bottom of your screen. And for some of you, you may have to scroll down a little bit to have it reappear. And please ask your questions through that mechanism, and I will repeat them back to Shawna, and we will go from there. So I'm going to start with the first question that came in about a half an hour ago, and it's from Susan, who says, I have been told I have CMT. A genetic test was inconclusive. I'm 79 years old. I see a neurologist. Where do I fit?
So as we often hear, and also, I don't know what that person's age of onset was, but we often hear that people think that like a later onset, for example, means like even in the 50s, 60s, 70s, that means that they don't have CMT. That's not the case. You know, we see onset of symptoms during like a whole lifetime. So it doesn't mean that the only genetic types are the ones that are happen in childhood. However, sometimes if they're, for example, CMT type 2 or they're later onset, sometimes it can be harder to identify the genetic cause. Probably that person was told they had inconclusive results because a panel or a number of genetic tests, I don't know how many genes were tested, were performed, and it didn't come back with a specific positive result, meaning they couldn't define the genetic cause with that testing alone. There are other rounds of testing that you can do. You can even do whole exome or whole genome on a clinical basis, or by attending one of our sites and getting involved. Those are the people that we want to capture through this gene discovery program, is finding folks who have had clinical testing, have not found the genetic cause, and then offer them research-based genetic testing. It takes longer, it's free, but through the INC, because we have grants that cover this process. But this is how we are capturing new forms of CMT. And like I said, we have over 100 different genetic types now. Colleagues and myself believe that, eventually we'll probably have around, 200 or 300 known forms of CMT when we find all of the genetic causes. But some of these are going to be more rare. And so it's kind of finding those individuals, helping to define what their symptoms are, like I said, based on CMT type 1 versus 2 and stuff. And then doing research-based genetic testing can help as another layer to identify the cause.
Well, for some of you that may have missed parts of Shawna's presentation, she showed a funnel that essentially demonstrated that as you increase the number of genetic tests and the size of the panel, it's probably going to also increase in cost. So it sounds like working with the INC is a cost-effective alternative to trying to find that out commercially. Is that right, Shawna?
I would say that that is true, but also the other limiting factor is, for at least for CMT, is if you've done a pretty big sizable panel, like 100 genes or something like that, and that's negative, the likelihood of you getting a positive test result based on exome, clinical exome, is pretty low, because in the clinical setting, they can only report out on those known genes. They can't look for other genetic causes that haven't been associated with CMT before. So if you've already screened out the most common forms of CMT, taking that next step to an exome, it's going to be a low yield for you. I mean, it's not, I actually just had someone this week who ended up doing a panel that was negative and doing an exome. And we think that therein lies the answer in the exome. So it's not unheard of. It's just that at that point, you've already screened out the majority of forms of CMT. And so moving over into the clinical side can also, or the research side, can also help us to look at other genes and identify new genes or new genetic causes of CMT that the clinical lab can't do. Another way of doing this is, for example, if you've had whole genome or whole exome, there is a consenting process that we can do at that clinical laboratory, where if you approve and sign appropriate consenting, we can transfer that data to our research platform. But that data has to be interpreted based on your symptom presentation, again, when things started, your family history, all of those details. So just having a lump of genetic data is very complicated. Like I showed you, it doesn't really tell us a lot about that person. So really, like, evaluating that individual, looking at when their symptoms started, how they progressed over the time, what we call phenotyping, is essential for this process of then interpreting genetic information.
Okay, here's a question from someone who chooses to remain anonymous. It says, it sounds if genetic testing is somewhat of a subjective decision, but is it recommended if you do not know your type?
I wouldn't say, I don't know if I would use the word subjective, but I would say it's a personal decision. That's how all genetic counselors approach genetic testing, especially in the world where, for example, it's not going to change, medical intervention necessarily right now in 2021. But we see there's tons of things on the horizon, which we saw today. And a lot of those things are going to be type specific, meaning you're going to need to know the genetic cause in order to be eligible for those trials. Or then we hope that those trials are going to lead to, a treatment. And so then you're going to need to know that genetic cause in order to have access to that treatment as well. And that then when you have a treatment for disease, that changes things radically. I mean, for example, with I think there's mention of like SMA on the talk before, that treatment radically changed the recommendations, because in those cases, a lot of times we could do genetic testing and diagnose those infants, but it didn't change the course of the disease. They still got profoundly weak and died early on. So, but now, because there's a treatment, genetic testing for SMA is now on newborn screening, and we're trying to identify people as early as possible so that they can have access to life-changing, life-extending medical care. And so that's a lot of times what changes when you're deciding about genetic testing is, yes, right now, that is true that most forms of CMT, we would still recommend physical therapy, occupational therapy, different management options to treat someone, no matter what their type is. But that may change in the future, and if we have medical intervention, then we may more strongly recommend people get genetic testing to have access to that. And like I said, in terms of the testing approach, we go through all the pros and cons of testing. And for some people, or a lot of people that I hear about, they're doing it for their family. They want to provide information for their family, their kids, their siblings. Doing genetic testing can be like giving the gift of information. And so that's why a lot of times people decide to do that. And there's other reasons as well. So I would say that it is personal, and that's why we make time to kind of go through those reasons and explore that person's choice, whether they want to get testing or not.
Great, thank you. Here's a question from Europe. It's quite specific. It's also quite late in Europe. I've been diagnosed with CMT2. After gene testing, I was told that they could not find any type of known genes responsible for CMT. I am female, I have a daughter. How can I approach the topic to find out whether my daughter is also affected? There's no family history because my mother was adopted, and her symptoms are only slight hammer toe, scoliosis, and my brother have no signs of CMT.
So they
I might be asking you to make a diagnosis over distance.
Yeah.
Hard.
They are probably saying CMT type 2 because there's axonal changes. So when they do nerve conductions, they are saying that the problem is starting in the axon. And so that doesn't give us the genetic cause though. And without a known family history to interpret, the chances go back to any inheritance pattern. That's why in that situation, finding a genetic cause would be crucial to knowing what the risk is to her daughter, because this could be a recessive type, it could be a dominant type. There's really no way in knowing based on when you have no family history. And even when you do have a solid family history, it can be challenging. So in that situation, identifying the genetic cause is the only way to interpret risk for the daughter. And I would say it also depends on when you had genetic testing. Like I said, genetic testing can change over time. They are identifying new genetic causes, and those go on panels and stuff like that. So, if you've had a one and done sort of test 5 years ago or something, it's enough. I would encourage you to go back to your providers, your doctor, a genetic counselor, and see if it's worthwhile running another test again, or getting involved in some of our gene discovery programs.
Okay, thank you, Shawna. We have about 5 more minutes, so I'll try to get to as many questions as possibly can. I'll ask you, Shawna, if possible, to shorten your answers in this kind of lightning round of our last bunch of questions. If you've been diagnosed with CMT, do your parents need to be genetically tested as well in order to confirm the type that you have?
So everyone in the family would have the same genetic cause.
Okay.
A lot of times when we just diagnose one person, like with CMT1A, that means everyone who has symptoms has the same genetic cause. So you don't actually have to type every single person.
Okay. If you are able to narrow down the type of CMT you have by symptoms, would you still be eligible to participate in clinical trials specific to type?
If you, it depends on the eligibility of the trial.
Mm-hmm.
For example, we had a trial that we were running where it was, you would be eligible if you or a first degree relative had a genetic type of CMT1A. So if you have the same symptoms and you have a first degree relative, like your parent or something like that, then you didn't have to do genetic testing yourself. You were still eligible. If we don't know the genetic cause in the family at all, and you're just having symptoms, right now, the way that the trials are running, you wouldn't necessarily be eligible until we knew what the genetic cause would be.
Got it. Thank you. How do I access the breakout room for the, well, he's already in this question. He says, I was 16 years old and was told that I had a type CL6, but that appears not to exist anymore. Any reaction to that?
Yeah, so there, historically, there are lots of different ways how CMT was defined. Some of those terms are no longer used. So for example, a very common one was CMT type 3, which was anyone who had an early onset, like childhood or early onset severe form of CMT. But once genetic testing started to become available, we found out that lots of different genes can lead to that type of manifestation of symptoms. And so CMT type 3 was just a collection describing a phenotype that it didn't really lead to helping us define a specific genetic cause. So that type, also called Dejerine-Sotis syndrome, that those kind of two descriptions are mainly just used to describe someone, to show that someone has a severe early onset presentation, but it's really not used in terms of our diagnostic system anymore. So there are historical classifications that may or may not be, currently used in this current classification system.
Great. Here's a question. Maybe we can just get a yes/no answer.
Okay.
Has the CNYE1 gene been implicated in CMT type 2?
Off the top of my head, I have to look up a lot of things when we're talking about stuff. So I can, if someone wants to email me later, it's again dependent on, like, a lot of times the specific genetic change and where that changes and things like that. So that person can email me.
I think that we are about at the end of the session. I think we promised everyone we would try to stay on time, and it's almost 3 o'clock. And so I'm going to ask everyone to log back into the main sessions. You may, in fact, end up being logged back out again as we do specific chats. But just link back into the main session that you used. It should still be live in your browser. Shawna Feely, thank you again. You were terrific. We very much appreciate your participation.
Thank you.
All right, take care.